All right, so any questions on the material we covered last time? We'll just finish up the behavioral section briefly, and then we'll get into the HIV and STD section coming up, okay? So anyway, so ADHD, how are we going to manage this? How do you think? Caffeine? Maybe caffeine could help out a little bit. Sometimes that can worsen someone's ability to pay attention, right? Some people... What'd you say?
It applies to children a lot of times, right?
Yeah, well, what about adults, though? ADHD. We're starting to see a lot more either kids that are growing up with ADHD or getting to the point where they're having more adult onset ADHD or being recognized later on. Oops, I should probably put this into presentation mode. Anyway, so whenever you're managing these patients here, it's really important to set goals in terms of what you're hoping to accomplish, right? So do you want them to be able to sit still in class for 8 hours a day as a PA student? Do you want them to be able to at least complete their homework when they go home? Like, these are things you want to consider here. Really big things here are going to be the non-pharm stuff, right? Because you'll find that the majority of the medications we use for ADHD, guess what? They're controlled substances. Most of them are C2 controlled substances. So, risk for addiction and dependence are big concerns we have for these patients here, and some other things we'll look at as well. So look at the educational, cognitive, behavioral sort of interventions that you can have there. And it's important to keep sort of a unified front between kind of what their experience at home versus what they're getting at school in terms of behavioral sort of interventions there. So we'll find that for ADHD specifically, once it's diagnosed, that stimulants are going to be our first line. And so these are all going to fall within the amphetamine category. So if you hear things like Adderall and you hear things like Concerta and Vyvanse, these are all amphetamines essentially. So they're in the same family as crystal meth, if you had to think about it that way. And they all work exactly the same way, which is why you do see a lot of abuse of these medications. You'll see a lot of patients will use these for recreational purposes, not just so that they can study and sit in class for without any attention issues. Basically, they have a couple of different mechanisms here. So first off, they're going to block monoamine oxidase. So they actually help to increase levels of things like serotonin and norepinephrine. Also, dopamine is going to be highly affected here, because remember, what's the main neurotransmitter related to addiction? So dopamine, right? Remember those dopamine squirts we talked about, how you can get addictive properties from that, and releasing dopamine in that mesocortical pathway. We'll also find these drugs can block the reuptake of these neurotransmitters as well. So not only do they prevent the breakdown, they block the reuptake, and they can actually increase the direct release of the catecholamines. So you get this big flood of catecholamines into the synapse, and that's what's going to be able to raise up that attention, being able to pay attention for better or longer periods of time there, right? You'll find that if a patient fails one of these agents, it doesn't mean that it's going to be across that class. So they can potentially try out a different agent. I'll give you the different ones here in a second. But for instance, if they fail dexmethylphenidate, doesn't mean they will be a poor responder to dextroamphetamine. You can try within the class there. Very frequently, these drugs are going to be extended release preparations. What do you think that is? Why is that important? Maybe it can deter abuse potential, but a lot of times people just crush up an extended release product and they can just snort that at that point. Yeah, exactly. So you want it to be able to last during the time periods. Imagine a kid getting sent to school, like frequently, because it's a controlled substance, it has to be held by the school nurse. If they had to receive it 2 or 3 times when they're at school, they'd have to be disrupted from class, go out, So there's issues with that. So we frequently will just give them an extended release product, so they get 1 dose in the morning, and then they're generally good until the evening time there. So because of that, we typically go with that. But the other concern would be the abuse potential with these things if you crush that, because if you crush an extended release product, what happens to that drug? It's not extended anymore, and it's all released at the same time, which is frequently what people are typically going for. So here are the different ones you're going to run into most frequently. We have things like methylphenidate. There's a lot of different brand names you'll find for these. These are typically related to the dosage form that they are. So for instance, like Quilivant is a liquid preparation that might be good for younger kids who can't take tablets or capsules yet. Dexmethylphenidate is a Focalin. We have these mixed amphetamine salts, which is your classic sort of Adderall. That's basically a mixture of amphetamine and dextroamphetamine together. And then we'll have lisdexamphetamine or Vyvanse. And this one's actually pretty interesting because it's actually a prodrug. So this one being a prodrug means it's inactive in its normal form, but if you take it orally, it'll go through the liver after being absorbed and be turned into the actual dextroamphetamine that does its thing. Why do you think we would want to administer this as a prodrug? Yeah, so you actually can't snort it. So it's going to be basically an abuse deterrent. So that way, if you were to say crush it and try to snort the medication, or maybe give it IV potentially, you'd actually find that the drug as a prodrug wouldn't really do a whole lot of things. So instead of giving a prodrug, you have to take it orally for it in order to work. Now, does that mean that every like 6-year-old that I see on Vyvanse was like snorting Adderall before this? No, actually a lot of people just find that the drug works pretty well. So I see a lot of kids are using it. It's a pretty popular one that I see frequently nowadays. Keep in mind that these are all C2s, so they undergo that same restriction as just like oxycodone or morphine or anything like that. So you can't do refills on these. You can do a max of 90 days. This is that situation where typically you'd write out, say, like 3 1-month scripts, right? So you'd say, okay, we'll fill this one today, and the next one you'd say, don't fill until 1 month from now, and then the last one you'd say, don't fill until 2 months from now, essentially. That's frequently done. Usually early on, you'll have the patient just come back to you month to month to see how they're kind of responding to it and see how it's working for them, to see if you need to change the dosage or change the drug. But once they get kind of stabilized, that's where you can write out for those longer periods of time potentially. Plus, you know, it's a financial incentive to you, right? They keep coming back to you. It means you got them on the hook, right, for more visits. I'm just kidding. You don't want to do that. So plenty of adverse effects with these drugs, which is why we like to focus on the non-pharm stuff first if we can and get that under control. Things like reduced weight and reduced appetite and weight loss. You'll see this with a lot of stimulant medications. That's typically why patients who are chronically abusing cocaine and amphetamines, typically they're not overweight because they have these stimulant activities that's increasing metabolism. They don't feel hungry. So that's a frequent thing you see with that. Why might that be a problem in kids? Because they're growing, right? Yeah, exactly. So you worry about things like growth stunting potentially that could occur because of that. Certainly insomnia is going to be a concern because, again, their brains are just kind of overexcited there, and we'll talk about some ways to manage that. This is why we typically just give these in the morning and not in the evening time, because they would just be wired all night. Sometimes I feel like my kids might have gotten into some Adderall in the middle of the night with the way that they act sometimes. But you will find some tachycardia, hypertension, and that makes total sense too, based off its mechanism of increasing release of those catecholamines. They're preventing the breakdown of the catecholamines, so yeah, they're going to see increases in their vital signs from that standpoint as well. Note the black box warning for these. You want to be cautious with patients who have any kind of, like, say, untreated like psych history and things like that, because you can see psychotic episodes and hallucinations rarely, and then we do worry about the abuse and dependence potential. And actually, I've read several stories of really sad cases of patients who they went through high school basically on Adderall the entire way through, and all of a sudden say they don't go to college or something, and their doc says, well, I'm not going to give you any more, you don't need it. And guess what? They built up years of tolerance of the drug, and all of a sudden they are trying to find a way to get back what they need from a physical standpoint, and then they end up devolving into addiction, right? So it can be pretty difficult from this standpoint. We'll try to find ways that we can maybe like give them breaks from the drug in some cases, to try to decrease that sort of body burden there. And again, do kids necessarily need this year round? Maybe not, right? So again, if it's during the summertime and they're not going to school, like maybe it's okay if they're off of the medication for that period of time. That is going to be useful to kind of decrease some of that physical dependence.
I have a question.
Yes.
Do you feel like those drugs are overprescribed here in the States when it comes to children and all this issue?
Maybe it's there. I mean, there are guidelines. If you go to the DSM-5, like that will tell you the guidelines specifically on how to diagnose it. It's difficult to say. There are a lot of children who are being managed on these medications here, and we'll talk about some of the other meds as well, but sometimes you're giving them stimulants in the morning and then you're giving them more sedative sort of agents at nighttime just to make sure they get to sleep. So it can be quite difficult. You're kind of chasing their tail in a lot of ways there. But it's certainly a concern of warning about overprescribing. I mean, like, do my kids have ADHD? I feel like they do. I mean, like, took my kids to the park yesterday. Yeah, my 2-year-old is just like, she basically just runs like an entire mile just back and forth up and down the park. I'm just like, where do you get this energy from? But yeah, exactly. That was the goal. It didn't work. No. Anywho, so as I mentioned, the high abuse potential, be cautious if you have patients with a substance abuse history, because this can then trigger sort of the same pathways you'd want to be cautious with. And there are sort of withdrawal effects. Now, if you're withdrawing from something like a benzodiazepine, what does that look like? Maybe seizures. Maybe to a lesser extent, what would you see? Be more excitation, you may see anxiety, you may see tachycardia, all these different things that are related to that withdrawal from a sedative agent. What happens with the withdrawal from a, say, stimulant agent? They may not have bradycardia. You usually don't see as many like vital sign changes here, and this is going to be more mild than you would see for something like a benzo or alcohol withdrawal. But basically, they're just not going to have a ton of energy. Maybe kind of moping around. Maybe it worsens their depression. It's just going to be kind of one of those things you'll see with that. So certainly, you can get withdrawal effects, just like you get withdrawal effects from caffeine, right? If you guys cut off from all your caffeine sources right now, it might not be a pretty picture. Even more of you would be asleep than normally, right? But as I mentioned, there is concern for some growth stunting. Hopefully it's going to be pretty minimal in most children, at least of what they found in studies. And we do like to perform those drug-free periods throughout the year. So you typically summertime, but just depends on what's appropriate for that kid. So what are some agents that might be useful if you, say, did not want to use a stimulant, or maybe it was not appropriate based off the substance abuse history or something like that? This is where atomoxetine or Strattera comes into play here. And so this one works specifically as a selective norepinephrine reuptake inhibitor. So kind of like some same mechanism some of our antidepressant drugs we've talked about before, like our SNRIs, kind of similar but more specific to norepinephrine. Better for adults in a lot of cases here, especially if you did not want to use an amphetamine product. However, onset is going to be slower, just like what we saw for depression, a couple of weeks before it kicks in, versus something like an amphetamine, like that's immediately going to be acting. That's why people will talk about like that rush they get from amphetamines and things like that is because of that sort of immediate effect, versus this will take a while. The benefit, though, there's no abuse potential that we have to really worry about from that standpoint. Okay. Other things to worry about, though, in terms of adverse effects you're going to see pretty frequently include things like hypertension and tachycardia. That makes sense because you got all that extra norepinephrine sort of circulating around. And we do worry about things like black box warnings for suicidal ideation, just like what we saw with our other antidepressant medications previously. So that's another big warning sign there. We have some agents that instead of sort of perking the patient up, so to speak, in terms of their attention, we can do things to kind of bring them down a little bit and sort of decreasing excitation. And so this is where alpha-2 agonists come into play. We've talked about these before when we talked about clonidine and guanfacine. Basically, they work on those presynaptic alpha-2 receptors, and they activate those, and it shuts down release of things like norepinephrine from the sympathetic nervous system here. And so by doing that, it is thought to help kind of decrease excitation. Some cases it's thought to maybe help improve memory, maybe have a little bit better blood flow to places like the prefrontal cortex. However, they tend to be not as effective as the stimulants. Really things like Adderall, like those are going to be kind of your gold standard for most patients. In terms of adverse effects here, you will see some sedation. Sometimes we're using it for that purpose there. So as I mentioned, you might see a kid like on Vyvanse in the morning time and then maybe on a dose of, say, guanfacine in the evening. Try to help bring them back down. Now, is it a good idea to treat the adverse effects of one medication with another? Not ideal, but sometimes you got to do what you got to do, right? And then we do worry about things like hypotension developing here. Bradycardia might be a risk, and then constipation can be relatively common with this set of drugs too. That kind of makes sense. Everything's kind of slowed down a little bit. So again, therapy has to be really individualized based on the patient, what the goals are, what kind of support you're going to get from a sort of parental standpoint, or if they're an adult, what sort of behavioral techniques you're going to be able to participate with. Consider things like their comorbid conditions. If I have a patient with uncontrolled hypertension, obviously something like a stimulant is not going to be a great idea, whereas something like, say guanfacine or clonidine may be more appropriate because it would treat that hypertension anyway, right? And then consider as well, are they not able to pay attention in class, maybe because they have an anxiety issue that they're dealing with? Like, also consider other comorbid behavioral health conditions you need to take into account as well. Okay. Any questions on that? Yes, ma'am.
So Strattera would want the drug holidays, like summer break.
I don't think it'd be as necessary, for sure. Yeah, and again, like there's no abuse potential with that one, so it'd be fine if they're on it sort of year round. I had one friend in pharmacy school in particular. He had suffered, he'd never actually been diagnosed. It's kind of like before that period. He was a kind of an older student, so he never was really at that period where they were giving out a lot of amphetamines. And so he was actually on Strattera, and actually one of the big things he noticed was he actually had pretty significant weight loss. Actually ended up noticing a lot of appetite suppression with that one, but it was nice from that standpoint because it was also not a controlled substance, and he didn't mind the weight loss either because he's a little overweight to begin with, and so it was kind of like a win-win for him. He's able to kind of better participate and can pay attention in pharm school.
Do you have to monitor LFTs or anything for these? Because sometimes liver injury.
Yeah, for something like Strattera, I would consider monitoring for that since that does have a history of causing liver dysfunction. For the amphetamines, not necessarily. I don't know if I'd necessarily watch that. The vital signs I'd be more concerned about, because it will cause increases in blood pressure and heart rate and whatnot. All right, if no other questions, then let's go into our next section, talking about HIV and STDs. I hope this doesn't become relevant to anyone with spring break coming up, right? Everyone's going to be just studying the whole time, I imagine. What about this? I'm just kidding. Let's talk about HIV first. What is HIV? Have you covered this anywhere else yet? Yes? Okay, so you're experts on it, correct? No? Oh. It's a spring break problem? Okay, so what is HIV? What is the virus? It's a virus, yes, thank you. What does it do? It affects humans, and it causes immunodeficiency. That's pretty good, right? So you already got 3 facts down about HIV virus, right? This is a really kind of interesting topic, and this is one of those things that is like always changing. You're always seeing new changes in terms of like therapy for these for this disease state, and honestly, like if you look at the history of it, have you watched any like movies about the HIV epidemic back in the 80s? There's a movie called like "In the Band Played On." There's a documentary on Netflix a while ago. I think it was like How to Stop. I can't remember the name of the movie, but there's been lots of documentaries about the HIV epidemic in the 80s and how things have really changed, right? So back in the day, if you got this in the 80s, like it was pretty much a death sentence. Like you were just not going to make it, right? And what do these patients usually die of? Yeah, usually secondary infections because they don't have an immune system to fight off this stuff anymore. Just like you would see with cancer patients, we're giving things that are immunosuppressive. This is the same thing, right? Nowadays, though, these patients are living pretty long, full lives. And in fact, now what we have to deal with is all the secondary complications of the medications we give them, things like diabetes and heart disease and things like that. So it's definitely made a big change. If you think about it, it's really not been that long a period of time. So it's pretty interesting from that standpoint. So this is a retrovirus. What does that mean? Well, basically what it does is it's going to inject its own DNA into our DNA such that it's going to make our cells start to work for it, right? So our cells are going to start to actually produce the virus itself, you know? So it's like there's retroviruses, which are like, you know, back from like the 70s, and you have like the hipster viruses, and I'm just kidding, no, you don't have that. There are 2 main varieties, HIV 1 and 2. You'll find that in certain areas of the world that one may be more predominant. You find here you can get a mixture between the 2. And so obviously what's the primary way that it's transmitted? Needles can be one thing, so like, you know, IV drug abuse is a big risk for developing HIV. What else? Yeah, sexual transmission, you know, via unprotected sex. So big risk here, right? Basically what you're going to find is that by causing the cells to kind of start reproducing the virus itself, it's going to then target these cells that express the CD4 receptor. So it's going to be a lot of like your T lymphocytes and monocytes and whatnot, and will eventually deplete those levels, right? So when you look at like what we monitor for with these patients here, you're going to find there's 2 big monitoring parameters we look at. What's one of them? A CD4 cell count, right? And then and what the other one is? The viral load, right? So one will tell us the extent of how much destruction we've had in the immune system. The other one tells us how rapidly replicating the virus is, right? So we want ideally one to be low and the other one to be high, and we'll talk about that in just a few minutes here. Mainstay here that is going to be this highly active antiretroviral therapy. So if you hear about heart therapy, it's not a cardiovascular thing, it's a HIV thing we're treating there, right? So when does HIV turn into AIDS? Yeah, so there's certain cut points. So if they get like an AIDS-defining illness they talk about, so if they develop like a PCP pneumonia, there's other cut points as well that when they actually develop AIDS specifically. So I want to talk about the HIV life cycle here a little bit. You've probably covered this, but this is important because this will give us different targets where the drugs are going to work. And again, remember, you want to use drugs that are going to have synergistic mechanisms, and we'll look at how we can do that via different parts of the life cycle here. And so this is a good slide to actually go back to and review if you want to look at, say, where the different drugs are going to be working at specifically. So let's say here we have the HIV virus. And it's going to be popping into the actual cell itself. And so again, it's going to be trying to find those cells that express that CD4 receptor here. And so there's a couple of ways we can already sort of interfere with the virus actually getting into the cell in the first place. So if it doesn't get into the cell, then that's great, because then it can inject its own DNA into our own DNA, right? So what you're going to find is we have things like entry inhibitors, things that will prevent the actual virus from getting into our cell itself, or we have things that may be preventing some of the receptor binding that we'll look at in a little bit. Once it's into the cell, then it's going to take its RNA, copy it into DNA, and then it's going to cause this integration step to actually occur here. Basically what's going to happen, this integration is going to cause basically the virus to inject its DNA into our DNA, and then our cells start to produce the virus itself. And so then we'll find that there's ways we can actually affect this in terms of either producing RNA or DNA for the virus. There's a way we can affect the actual assembly of the actual proteins together. And then we'll look at some ways we can actually manage the actual processing of those proteins and prevent it from ever becoming a kind of fully formed, mature sort of virus. And then the cell will just spit it back out and it goes on to infect another cell, okay? So look at those different steps in more specificity later on. But basically, as I mentioned, it's really important to know that so you know how the drugs are working, right? So again, the CD4 receptor is really important. That's what it's specifically looking for in terms of cells to target. We're going to look at a CCR5 receptor that some people will express that also helps the cell, the virus to bind a little bit tighter or bind more easily to the cell. So that'll be another drug target we'll look at a little bit. Once it's internalized, it's going to be able to use its DNA polymerase to go ahead and form a DNA here, and against that complementary strand here. One of the things you're going to find is that this reverse transcriptase is going to be a really important target, but it's also really kind of a sloppy sort of protein. You're going to find that it causes a lot of errors to occur, a lot of mistakes to happen. And what do you think that does in terms of, what implication do you think it has for our drug therapy? Hard to treat, right? So you're going to find that resistance is going to be a big issue here, because we may have drugs that are looking for specific targets, but if the virus mutates such that the drug can't recognize that anymore, it's going to become resistant. So resistance is a huge issue with HIV. You're also going to find that a lot of patients who are most at risk for complications of HIV, you want to think about patients who are maybe like homeless, may not have good compliance with these medications as well, and they're also going to be another really big source for resistance. And guess what? If you have a resistant form of the virus, and you say share a needle with someone else, guess what? You might share that resistant form to that other person as well. So that can be another big problem you run into. So anyway, so again, once that double-strand DNA is going to then get integrated into the host DNA, right, via this enzyme integrase. This is going to be another important target, and this is becoming one of the sort of the first-line drugs we're going to start to use. It's kind of changed a little bit. But this is going to be a big target we'll look at. And then now our host cell is producing its own viral RNA and proteins for the virus itself. Then gets released, and then we'll be able to infect new cells. So typically, when they get sort of the acute infection itself, you may find they'll have this retroviral syndrome. They'll kind of feels like sort of like a like a mono sort of feel, or they'll have this acute sort of infection. But this is mainly going to be kind of targeting this latent period. You'll find that the disease state itself will be kind of under the radar for a long period of time, where it will be sitting there just quietly replicating, but your patient may not experience any complications of the disease because they have a pretty good say reserve of immune function. We'll look at the chronic issues that develop here in terms of the complications. We'll look at certain cut points and when we want to actually like prophylax against certain disease states for these patients versus treatment. And as I mentioned, kind of when they get these AIDS-defining illnesses, things like PCP or Kaposi sarcoma, that's when they have full-on AIDS at that point there. And we know the monitoring, you're doing CD4 cell counts, and you're also doing the viral load as well. So typically, which one do you want high here? CD4 count high, and the viral load you want to be undetectable, ideally, right? You want to be not even able to measure any of that in the blood. So obviously our big goals here are to decrease morbidity and mortality over time. As I mentioned, back in the 80s where we didn't really have any good drug therapy, this was a death sentence for patients. Nowadays they can live for decades potentially with the disease based on the new treatment that we have nowadays. And again, this is something that's constantly changing. So if you work with these patients, you need to be able to keep up, and I'll show you the website where you can find that in just a little bit. But again, as I mentioned, we want to keep up the CD4 count as high as we can while helping to keep the viral load as undetectable for as often as possible. So generally what we're going to find is that, as I mentioned, the viral RNA is going to be expressing kind of that magnitude of replication. So you may find as well, that not only is resistance an issue, but compliance is another one too. So making sure that your patients are being compliant, because otherwise you will find pretty elevated RNA counts in the blood there. So what we're going to do is when we give the heart therapy, we'll look at the different drugs we're going to use in a little bit. The idea is it will help to suppress and prevent the virus from replicating itself such that the viral RNA is going to be undetectable, and then it's going to prevent the destruction of those cells such that the CD4 count is going to remain higher for longer there. For the most part, you're going to find, and actually this is one recent change, but for the majority of therapies are going to include at least 3 drugs, okay? We're talking about heart regimens. That's definitely going to be something I'll probably ask on the test, is like which one of these is an appropriate heart regimen. And so you need to be able to identify the different classes of drugs that these fit into and which ones make sense to combine together, because it's a very certain prescribed sort of combination, not just kind of just pick 3 random drugs and then you're good to go, right? You're going to find that it's fairly limited in terms of new antiretroviral drugs coming out all the time. Because again, if you had to think about, as a drug company, would you rather make a new drug to treat hypertension or a new drug to treat HIV? Why hypertension? As a gazillion people with hypertension, this is a relatively more niche sort of subset of patients here. So if you're thinking about it from a money-making standpoint, there's not as much incentive there. But you're going to find that once patients become resistant, I mean, sometimes you'll find they become resistant to one drug in the class. That whole class is gone at that point, right? So it can be pretty detrimental if they become resistant. They may run out of treatment options in some cases there. So pretty problematic. This is kind of interesting too, is like, when do we start treatment for patients with HIV? Anyone know? Immediately. That was not always the case. It used to be, even I think back when I was in school 10 years ago-ish, maybe 11 or 12. No, I graduated 10 years ago. But, you know, this was something where it was actually at certain CD4 counts you would treat. And they actually, they would actually wait. Yeah, you know the patient had HIV, but you would wait until, say, the CD4 count was down to, say, like, you know, say 100. And then you treat it. And then say, well, actually, that's too big of a risk. So, you know, patients are getting infections. Let's do it at 200. Nowadays, we just say, just treat them all, right? Because what's the benefit? You keep that immune system competent for longer, right? And so we actually found that it's just, there's no point in delaying here. We only find issues if we do that. The thought process, though, with waiting was that maybe you can keep them, you keep more drugs sensitive to the virus for longer periods of time. So instead of starting off right away, you maybe can help stave off some of that resistance. But nowadays, we know just start treating immediately as soon as you got the diagnosis, okay? So that way we also have reduced transmission, so people are less likely to spread it to other people, and then you have fewer AIDS-defining illnesses, which is beneficial to your patient. Here are the main classes of drugs we're going to be looking at. We're going to look at our integrase inhibitors, which these nowadays are becoming kind of the first line, one of the first line drugs recommended. This, again, is a relatively new class of drugs. We'll look at our nucleoside or nucleotide reverse transcriptase inhibitors. These would be your NRTIs. We'll look at our non-nucleoside reverse transcriptase inhibitors, the NNRTIs. We'll look at our protease inhibitors, some entry or fusion inhibitors, and then co-receptor inhibitors. Okay, these are all different ways along the viral life cycle that we can interfere with the reproduction of the virus itself. You will find that just like in cancer, that people who work in HIV, they love their acronyms. And you're going to find that frequently the drug acronyms don't make any sense compared to what the actual name of the drug is itself, but they always do that. What's the problem with using acronyms if you're unfamiliar with them? You may choose the wrong drug, or you not know what something's talking about. So if you're ever dealing with these kind of patients, make sure to look stuff up if you don't know. I'll just give you the examples here just to show you what they are. I'm not going to have you identify an acronym on the test and say, which drug is this? Because frequently it doesn't make a lot of intuitive sense unless you actually knew the actual chemical name for the drug itself. So just to give you some examples here, let's start off with our nucleoside reverse transcriptase inhibitors. And so you can see here, like stavudine is D4T. Like, that doesn't make a whole lot of intuitive sense to me, but if you did this every single day, you would just know that, yeah, it's stavudine, obviously. Or like zidovudine is AZT. Like, a lot of it goes back to the more specific chemical name for the drug than the actual what we market it off of. So anyway, starting off, we have our nucleoside reverse transcriptase inhibitors. These are basically based off, in terms of structure, off of purines and pyrimidines nucleotides. And I'm not going to have you know specifically, is this one, zidovudine a thymidine versus a deoxycytidine? I don't really care if you know that specifically, but you should be able to identify any of these as an NRTI, okay? Basically what these are going to do, and just similar to what we saw with, say, for instance, like our, let's say, cytarabine from treatment of chemotherapy. Remember how cytarabine worked? Our Ara-C. Remember that it actually got incorporated into the DNA of the cancerous cell, and then it was a chain terminator. You couldn't add on any nucleotides after that. So that prevented replication of DNA in the cancerous cell and eventually led off to apoptosis, right? Remember how that worked? This is doing the same thing there, right? So these are getting incorporated into that viral DNA or RNA and preventing further replication. So that way you're inhibiting the reproduction of the viral DNA and RNA and preventing it from ever becoming a fully mature sort of a virus at that point. So we have things like stavudine, zidovudine. Zidovudine was one of the first ones we actually had here, AZT, and tricytidine, lamivudine, abacavir, and we have didanosine, and then tenofovir. A lot of these are going to be difficult to recognize just off the name alone because a lot of these will have vir at the end of the name. And normally think vir, you think virus. Well, guess what? A lot of these are, I mean, they're all treating a virus, but they don't really differentiate themselves that well. So I wish I had like something like, this one ends in statin, so you know it's a statin drug. Not going to be as beneficial here. So be able to just look at these drugs and make that association between them and their class, okay?
How long can HIV survive without being
That's a good question. I'm not sure how long it provide, because again, this is just working on the replication. The actual host virus itself, once it's in the cell, it's kind of there doing its thing, which is why we don't use these by themselves. We'll actually include this with another set of drugs, typically with a different mechanism to kind of help with the prevention of the replication of the virus itself. But yeah, I'm not sure how long the actual time frame is specifically. Good question. So, and again, just to give you a picture of what this looks like, we can see here that with the NRTIs, basically you'll find that normally those nucleotides get phosphorylated, right? So add some phosphate groups to them, you get a triphosphate form. And essentially, if you were to say looking at, say, a ribosome here, you have the viral RNA that's being copied over into DNA. Instead of just adding on new amino acids to that point there, adding on one of these NRTIs is like kind of adding that chain terminator. It's kind of putting a cap on the end of it, and you can't produce any more DNA off of that. Okay, so no more DNA being produced, the virus cannot replicate at that point. Can't produce new proteins, all that good stuff. And you'll find that typically for a lot of these regimens here, we're going to use 2 NRTIs together along with a third agent. So this is frequently going to be the backbone of most of your HIV therapy. 2 NRTIs, usually plus something else. And we'll look at those different classes in a moment, see how we can combine those. So a lot of times you'll find with these drugs is not only we're worried about just how effective it is for treating the virus itself, we're also worried about the adverse effects, and you'll find these are pretty numerous depending on the drugs we're looking at. And again, you'll find that it's be ideal if these drugs are completely specific just for the HIV virus, but you're going to find there is some crossover effect. It will affect our cells as well. So for instance, you may find that you develop things like peripheral neuropathies. You can see things like pancreatitis can develop here. You can develop lactic acidosis in some cases, right? So these are kind of things you'd worry about over the long term, and there's a lot of monitoring you're going to be doing for these patients, but you're probably going to be seeing them frequently anyway because you're monitoring their CD4 count and their viral loads and things like that regardless. Some of the newer agents, though, we do have a little bit fewer side effect profile, or less of a severe side effect profile to worry about. So things like abacavir and tenofovir tend to be pretty well tolerated. And in fact, a lot of the newer regimens that are first line recommended typically include 2 of these 4. Usually things like tenofovir and emtricitabine, or lamivudine and emtricitabine. Those are pretty common combinations you're going to see there. I'll show you what those look like in a few minutes. So one thing to note, though, that is a unique side effect of abacavir specifically is that before you start a patient on this, you have to check for this HLA B5701 mutation. If they have this mutation present and you start them on abacavir, they have a very high likelihood of having anaphylaxis to the drug itself. So again, probably as like a first-line regimen, you probably wouldn't include abacavir, but maybe if the patient became resistant to some of the other agents, you needed to start them on abacavir, you have to do this testing beforehand. Because if you don't, they may have anaphylaxis, and that's kind of on you because we know about this mutation. So switching gears and going to our NNRTIs, these are going to be non-nucleoside reverse transcriptase inhibitors. So we saw that the NRTIs inhibit the effects of reverse transcriptase by basically blocking off any further DNA from being produced off the viral RNA. Here we're actually going to find that these drugs themselves bind to the reverse transcriptase to prevent it from having any further replication there. So if you imagine here finding the NNRTI kind of binding to the reverse transcriptase and changing the conformation of the protein, that prevents the RNA from ever being converted back over to DNA. Okay, so if you had to think about it, would it make sense to use an NNRTI plus an NRTI? It would, yeah, because they're kind of working on 2 different sites to prevent reverse transcriptase from working. And so that, is kind of going by the wayside, but for a long time, that was a preferred combination there of using an NNRTI plus an NRTI, usually 2 NRTIs together. So a couple in this category include delavirdine, we have efavirenz, we have nevirapine, etravirine, and then rilpivirine. I think you can see their abbreviations there, but I'm not going to test you on that specifically. These ones tend to have fairly good side effect profiles, so things like rash, transaminitis, or seeing elevated LFTs, certainly you would be watching for. But other than that, not a ton of other side effects, which is why we use these for a good period of time. The issue, though, is going to be resistance in a lot of cases. You'll frequently find the virus will become resistant by mutating that reverse transcriptase pretty frequently, and you'll find that even a single mutation for one of these guys can actually confer resistance to the entire category. So you can become resistant to efavirenz, guess what? You become resistant to all of them at that point, essentially, which is problematic because, again, that's 5 drugs you can't use anymore for that patient there for the, the rest of their life, essentially.
For something.
Mm-hmm.
You said that the NRTS are the backbone of the therapy, right? And you have to check every single patient for that mutation, for the HLA?
Just abacavir.
Oh, okay.
Just abacavir. Mm-hmm. Yeah, just that one specifically. Yep. The one exception to that resistance is going to be etravirine. That one tends to still retain some efficacy, so you may still see some use of that one as a potential agent. Next, we have our protease inhibitors. So basically, if you had to imagine when the virus is starting to encode all this RNA and you're transcribing it over into the proteins themselves, they kind of come in this kind of sort of unfinished sort of form here. And so we need this enzyme protease to kind of chop up and change the forms of those proteins such that they can be more functional. If you inhibit this process, if you prevent the protease enzyme from actually chopping up those proteins there, the virus itself, even though you've got all the proteins present, they can't actually become a fully functional, mature sort of virus at that point, and thus it never gets sent off to be infecting another CD4 cell, right? So this is another one that you may find as a preferred regimen in some cases there, where you see, say, 2 NRTIs plus a protease inhibitor. That was another very common combination we used for a long time there. A lot of drugs in this category, as you're going to see. We have things like atazanavir, we have darunavir, we have fosemprenavir, indinavir, lopinavir. We'll talk about combinations with ritonavir in just a little bit. Nafinavir, ritonavir, sequinavir, and then tepranavir. So this one gets kind of interesting from a pharmacokinetic profile thing in terms of drug interactions. And drug interactions are another really big concern for this disease state as a whole anyway. In terms of side effects, we didn't like the protease inhibitors for a lot of reasons. We still use them, but they're not going to be as preferred, mainly because they have a lot of metabolic effects. So for instance, they can cause things like increasing your lipids, lipid panels. They can cause glucose intolerance. Not a big deal when these patients weren't living for all that long, because they didn't really live long enough to develop a lot of these metabolic complications. But when they were living 30, 40 years now with the disease state, you're going to find things like cardiovascular disease is a much bigger concern. Them developing type 2 diabetes is a big concern. And so these are things why we may not like the protease inhibitors as much anymore, because of the long-term complications. Also kind of interesting is you get this altered fat distribution or lipodystrophy, and they can develop this kind of buffalo hump is what they kind of term it there. It's kind of an interesting side effect of the protease inhibitor specifically. So kinetics are going to be important here, right? And again, all the agents we've already talked about so far have all been oral agents. So it'll be kind of one exception to that I'll make in just a little bit. These all get metabolized by the liver. So this is a highly kind of liver-centric sort of disease state in terms of the medications we're using here. And so one of the things we'll see is that we'll use this process of boosting to increase the levels of some of the protease inhibitors we're using here. So I'm going to say boosting, that means we're actually going to be giving some of these medications with a CYP3A4 inhibitor with the intention of boosting up levels of the medication. Okay, so we're doing an intentional drug interaction to boost up our levels. Why do you think that might be useful? Because normally we like to avoid CYP3A4 interactions, right? That's basically it, right? So again, you're helping to have the drug stick around for long. Yes, you may get golf clap. You can certainly keep the drug around for longer. So and more or so, this is a compliance issue. So instead of having to give a drug, say 3 or 4 times a day, maybe I only have to give it once or twice a day by boosting the levels with using a CYP3A4 inhibitor. There's 2 main ones we're going to use here. One is ritonavir. Itself is a protease inhibitor, but frequently you're only going to see it being used as a booster. So for instance here, there's a combination drug of lopinavir plus ritonavir called Calitra, and that one specifically is using the ritonavir as a booster to get levels of lopinavir even higher. And actually of note, I've seen a study or two, they're looking at new novel treatments for the coronavirus, and you actually may find some of these drugs being used there. I know one of them was using Calitra as a management in addition to something else to help manage the coronavirus. But anyway, so the other one is going to be called cobicostat. Is also another potent 3A4 inhibitor. So do these work specifically just on boosting other protease inhibitors? Can they boost anything that is metabolized through 3A4? Anything. So again, this is another big concern from a drug interaction standpoint. So like, for instance, if they were on, say, Calitra, lopinavir, and ritonavir for a long period of time, and all of a sudden their LDLs are skyrocketing and their triglycerides are up, you may want to put them on a statin, right? And we know certain statins will cause major interactions there. So these are all things you want to be thinking about in the case there. And again, you may not find that the person who's managing their HIV is the same person who's managing all their other stuff, right? Typically they're seeing an infectious disease provider for their HIV management, and then they're seeing a PCP for all their other stuff, potentially. You gotta make sure that communication's happening there so you know what they're on, so you don't cause any inadvertent interactions, right? So, as I mentioned, you get higher levels, better suppression, and less frequent dosing.
I'm confused by that whole
Well, not all the statins are CYP3A4 mediated, right? What were some safe ones we could administer? Rosuvastatin was probably your safest bet there, right? Because that was also the highest potency agent. There are a few more, but like atorvastatin, simvastatin, I'd be very cautious with using there, or maybe drop the dose pretty significantly to see how they're responding to it, right? So just big concerns there. And again, like I said, just having multiple providers all having their hands in the pie, it can be problematic if that communication is not good between the groups.
Is there any other 3A4 inhibitor? Do you need to use another one, or could you use a pre-existing one?
That's a good question, probably for someone who like does this day in and day out. I would probably look for an alternative agent if possible to avoid that, just because we know more reliably how well one of these two, like ritonavir or cobicistat, is going to work on boosting those levels. You know, when I say 3 or 4 inhibitors, not just a all or none kind of phenomena. You can have a weak inhibitor, a strong inhibitor. These are pretty strong inhibitors here. So I may try to find, you know, say for instance they're taking erythromycin for something, may switch them to like azithro. Maybe you'd have less of an interaction there. So. Okay, up next we have our fusion inhibitors. So these are actually going to be able to prevent the fusion of the actual HIV virus itself from fusing to the host cell to actually get into in the first place. So it kind of prevents them from getting into the cell at all. And so here we have enfuvirtide or Fusion. This one's kind of interesting because it actually only inhibits HIV-1. So if you had someone at HIV-2, and predominantly like in certain places like in Africa, there's a high predominance of HIV-2, this drug wouldn't actually be useful at all, right? So again, you may find geographical differences from that standpoint. And again, how would you know if you have HIV-1 or 2? Well, we're testing for all that stuff, and we'll talk about genetic testing in just a little bit. Basically, this one is going to be a peptide that we're administering, so it's a protein. So guess what? Has to be given via injection. So this will actually be a sub-Q administered drug for these patients here. And for the most part, you're going to find that while this drug is pretty well tolerated, it's going to cause a lot of injection site reactions, so a lot of pain, erythema, nodules that can actually form with chronic use. So again, not ideal. This is not going to be a first-line drug to start patients out on, but maybe like an additional add-on potentially. Another sort of very specialized sort of drug here is called a CCR5 antagonist. And so this is actually going to be one called Maraviroc or Selzentry. This is going to be something to where the HIV virus, while it's looking for that CD4 receptor, it's also potentially looking for the CCR5 receptor as well. And if it binds to both of those, it has an easier time getting in than if the receptor was not there. So this can be something that actually blocks a human receptor instead of actually affecting the virus itself. So it's kind of a novel mechanism there. It's really treating our cells rather than treating the virus. And so this is an important one because you'll actually find that if patients don't express the CCR5, I'm sorry, if the virus is not looking for that CCR5 protein, then it's not going to be a very effective drug because that virus is just going to get in regardless. So this is something where the mutations can actually occur to where the HIV virus may initially present looking for that CCR5 receptor, but then over time it will develop resistance by getting rid of that, and then the drug's not going to be effective anymore. So this is another one where doing prior resistance testing is really important for those patients. All right. The newest category here we have are called the integrase inhibitors, and so this is going to be kind of like the new mainstay of therapy. These are like the new recommended regimens for the most part from the NIH. And so we have things like raltegravir, dolutegravir, and elvitegravir, and then actually the newest one's called bictegravir. And so, and again, just to give you some examples, we have a lot of combo drugs you're going to see with this. So for instance, you have like bictegravir that gets put with emtricitabine and tenofovir. Right, so you get the integrase inhibitor plus 2 NRTIs. You had a full regimen in just 1 tablet. The benefit there is compliance, right? Because again, compliance is a huge issue. And if you look at like old school videos, like from the 90s of HIV patients, they're taking dozens of pills a day, and it was very problematic, multiple times a day. Nowadays, we have certain formulations you can just take 1 pill a day to treat your HIV. It's amazing how far that's really come in such a short period of time, relatively speaking. But here's an example here too of like elvitegravir gets combined with cobicistat as a 3A4 inhibitor to boost up levels of that as well, to keep those levels high. Basically what these are going to do is it's going to bind to the integrase enzyme that the HIV virus produces and prevents the viral DNA from getting incorporated into our DNA, right? So it helps to prevent the actual takeover essentially of our host cell and keeps that cell healthier for longer until that virus just go ahead and gets cleared out, and then you still have a healthy cell left around. So we're finding these are pretty well tolerated. So again, mild side effects, very effective. And so nowadays these are becoming kind of the first line recommended regimens here that includes an integrase inhibitor. So as I mentioned with the drug interactions, a lot of these are going to be on purpose. Like for instance, if I include ritonavir for some of these regimens, you're going to see that's intended to boost up levels of those drugs there. However, not everything is going to be playing so nicely. Like, so for instance, things like etravirine or nevirapine can induce CYP3A4. It may drop levels of other drugs that are going to be affected by that, right? Most of the protease inhibitors will have some degree of 3A4 inhibition, so you got to be really cautious and make sure you're checking out the interaction report beforehand. And then keep in mind, you may have other interactions like with other medications that patients may be taking. So for instance, what's a possible opportunistic infection these HIV patients can develop? TB, right? And so if you put them on something like rifampin, that can induce 3A4 and drop down levels of their other concomitant medications, right? May put them at more risk for other opportunistic infections. So be aware of that. Look up food-drug interactions. I'm not going to go through all of these here, but some of them are better absorbed with food, some without. So watch for that. And just when in doubt, just look it up. Now, who here specifically wants to work with just HIV patients? Right, not many of you probably, right? It's kind of a niche sort of thing that people are either really into or they're not. Are you going to encounter patients on these drugs though? Almost all of you will encounter, even if you work in surgery or ortho or anything like that, dermatology, you're going to run into these patients here. So you got to know their medications and how they may be affecting what you're going to be doing for that patient as well. So just kind of keep this in mind. So let's do a 10-minute break now, and we'll come back and we'll continue. Okay, continuing on. So we're talking about we have all of our medication classes sort of covered now. Now again, this is an evolving process. Every single year I have to come back and look at this website so I can update the slides to say what the new preferred regimen is, because that changes every single time. I'm still amazed, always changes. So if you go to aidsinfo.nih.gov, just memorize the whole site and you should be good for the test. Okay, no. But that's your main resource, right? That's where you can go and actually find out all this info. A lot of really good resources there in terms of managing it in special populations, like how do kids get treated versus pregnant women, like how do you prevent patients who maybe need chemoprophylaxis because they're in high-risk situations. All these different things are really handy there. What we do want to know, or what you should know, is basically what's like kind of an acceptable current regimen nowadays. And so typically, as I mentioned, you're going to have a backbone of 2 NRTIs plus an additional drug of a different class. Okay, so that could be an integrase inhibitor, that could be a protease inhibitor, that could be an NNRTI. Those are the 3 most common ones you're going to start out with. Nowadays, you're starting to see the NNRTIs are taking more of a back seat, mainly because of the fact that there's more resistance as a concern with those. We like the integrase inhibitors because 1, they're really effective, and then 2, you're going to find they have less metabolic side effects than a lot of your protease inhibitors are going to have. And in fact, one of the newer recommendations actually is just they had a trial where they actually had a really good results with just using an integrase inhibitor plus 1 NRTI, which is pretty wild that there's just a 2-drug regimen that they actually recommended as first line. Now again, these are for patients with a new diagnosis that don't have a lot of resistance already built up over time. So, but some other example regimens here would include things like, say, an integrase inhibitor plus 2 NRTIs, so like bictegravir plus tenofovir and emtricitabine, right? So you can end up, so you should be able to recognize the different drugs, what classes they fall into, and if it makes sense to use that as a preferred regimen, right? Or for instance, here we have a protease inhibitor plus 2 NRTIs, so maybe like darunavir plus tenofovir and emtricitabine. Now this is another thing too, where you may add on a 4th drug, and that may be ritonavir to boost up levels, or maybe cobicostat to boost up levels of whatever that 3rd agent's going to be there. So something you may see, maybe a 4-drug regimen. But the ritonavir, we're not using it for its protease inhibiting capabilities, for the CYP3A4 inhibiting capabilities there. And then something as an example of an NNRTI plus 2 NRTIs, maybe efavirenz plus tenofovir and emtricitabine. You tend to find this, these 2 NRTIs used pretty frequently together. It comes as a combo pill, so it's another thing that helps out with the compliance there. So as I mentioned, variable adherence is pretty common with these patients, either due to circumstance or just due to natural human behavior. You know, you may have these patients who are in socioeconomic sort of settings there where maybe they don't have good access to healthcare, maybe they don't have good access to coverage for some of these medications. That can make it very difficult to stay compliant there. And that's a problem because ultimately that can lead to a lot of resistance. So if you're only taking it, say you're supposed to take just 1 pill a day and you're taking it maybe every other day or maybe 3 or 4 times a week, you're going to find resistance is going to become pretty readily apparent over a short period of time. And again, other things like concomitant substance abuse issues, psychiatric illness, all these things may make it very difficult for them to remain adherent. So to help out with that, we want to use combo drugs whenever possible. Overall helps them limit their pill burden, how many pills they're taking in a day, and then also be aware of any kind of food restrictions and if that's going to be a problem for your patient in terms of their normal dietary habits. But some examples here, so we can use something like atriplo, just the favirenz and tricytidine tenofovir, just one pill they can do there. Or like eltegravir, cobicistat, and tricytidine and tenofovir, Genvoya, that's just a one tablet they could just take once a day. And again, those are going to be nice from a compliance standpoint. However, they may be more expensive, so insurance is going to be an issue for some of them. So resistance testing is going to be really important here. So just like you would if a patient had pneumonia, you'd want to go ahead and get a sputum culture to see what the cultures and sensitivities are. We can do the same thing here for these HIV patients. And so there's two main types of testing. There's phenotypic testing and then genotypic testing. There's going to be some differences between them in terms of helping us to determine what the appropriate drug therapy is going to be. So the easiest thing to do is just do a genotyping for the virus itself. You can just run the amino acid sequence and see, does it have certain mutations? They're going to make it more likely to be resistant to certain drugs, okay? So you can do a resistance testing there just to say like, okay, well, you know, it has this mutation. We know this mutation generally confers resistance to X drug. And maybe you would avoid X drug as your starter point, okay? Now, again, is this a case here where you would delay therapy to wait for the results to come back? Typically, no. You just want to go ahead and start them on something empirically recommended, like we mentioned a couple slides ago, and then when this testing comes back, then you may switch them up. So genotypic testing has its role. It's going to be a little bit more simple. It's going to be faster, cheaper typically. What's more beneficial, though, is going to be this phenotypic testing. And this is where actually you're going to be able to take, in comparison of the virus that the patient has compared to the kind of wild type virus, you're going to see what these drugs will actually do, sort of more of like an in vivo sort of, in vitro sort of testing there. And so basically it'll tell you, just like you do culture and sensitivity for an bacteria, you're going to find you can do the same thing here with this phenotypic testing. And it will tell you exactly, okay, well, based on the different mutations that the virus has, it is, you know, going to be susceptible to this drug but resistant to these two, right? And it's going to be higher cost, slower turnaround, but gives you more workable information, right? So using the genotypic testing is kind of like looking up a database to kind of see, you know, what you think is going to be resistant to. Phenotypic testing is doing the actual work to find, okay, specifically what is it really resistant or susceptible to. Can I make a difference? Or make sense between the two? Okay. So what would you do, say, for instance, if you had HIV in pregnancy, right? So generally you find that you treat these pretty similar to non-pregnant patients here. You're going to find that by having pretty maximal suppression in the mom, you limit how much can be passed on to the fetus. That's always going to be a good thing there. One drug you'd want to avoid is going to be efavirenz, because that's been linked to neural tube defects. So that one you'd certainly want to avoid for those patients there. And then actually one thing you may see being used as well is going to be zidovudine. It actually gets recommended during the intrapartum period, and that also will help to prevent transmission over to the child as well. And then we'll actually have fetuses that will be given, say, 4 to 6 weeks or so of just zidovudine by itself to provide that suppression to make sure that sort of the virus never gets a foothold in the first place. That can be another really effective way of suppression therapy to make sure they don't develop that in the first place. And then typically they recommend avoid breastfeeding for those patients as well. Again, that helps to decrease virus transmission and drug transmission potentially. Because again, the fetus, how good is their immune system starting out? Not great, right? So again, we want to do everything we can to prevent that virus from taking hold. So. I would have to do some more research on that to see specifically what they recommend. That may change over time, but yeah. And again, if you work with these, you know, patient populations day in and day out, like, you'll just kind of stuff by the back of your hand. But, you know, and again, how often do I see patients with HIV where I work? Not very frequently. It's fairly rare that I run into that. Occasionally we'll give zidovudine to a neonate, maybe transferred into us. Occasionally see a patient actually has who's on a full heart regimen, maybe like an adolescent, but it's still pretty rare. But depending on where you work in the setting, you know, it could be much more predominant or much more commonplace. So chemoprophylaxis, what does that mean? Giving you drugs to prevent the infection from happening in the first place. And so this is good in terms of either pre or post-exposure prophylaxis. So for instance, healthcare workers, are you at risk for contracting bloodborne diseases? Absolutely you are, right? So especially if you go into surgery and things like that. And so occasionally, like say you have an accidental needle stick, they're in rotations, you actually get stuck with a needle you just use to administer to a patient. One thing, it's really good to know what their HIV status is, but what if that patient already left and you can't track them down? right? Most people don't get tested for HIV unless they have a specific indication to do so. So in some cases, you may go with the worst possible scenario and say, okay, I'm just going to go ahead and start prophylaxis anyway. Typically, we like to start earlier the better, so within 1 to 2 hours of the exposure is always going to be beneficial there. And we give them a full 3-drug regimen. We actually do raltegravir as an integrase inhibitor plus emtricitabine and tenofovir. We may treat them for 4 weeks, right, just to make sure that if any virus did get in there, that it's not going to be able to replicate and prevent it from causing actual infection there, okay? Now, pre-exposure prophylaxis, what does that mean? You're taking it before you get exposed to the HIV virus itself, right? So who might that be beneficial for? High-risk patients, right? So for instance, like men who have sex with men typically find like receptive anal sex is like the highest transmission rate in terms of actually like passing it from one person to another. So that's a high-risk situation, right? So you may sometimes, if you have serodiscordant couples, so one patient has HIV, other one does not, obviously you're going to be recommending actual physical prophylaxis as well, but you can do things like giving them daily tenofovir and emtricitabine, so that way if they do have any exposure, they can be protected against that as well. Patients like high-risk drug abusers as well may be another high-risk population you consider there, but again, you obviously want to test them beforehand because you want to make sure they were actually negative to begin with, otherwise you should just treat them like a typical HIV patient. So as I mentioned with the outcomes we're looking for the CD4 count and the viral RNA load. We're going to see that you should do testing at the beginning. I wouldn't delay therapy, but go ahead and start at least with the genotypic testing, if not phenotypic testing. And then typically you'll kind of monitor them every 3 months or so until the HIV RNA is going to be undetectable at that point, okay? Now, reasons why you might want to change your regimen would include, say, for instance, that they were developing intolerable side effects. So, for instance, like back in the day when didanosine was being used more often, it causes awful diarrhea, like uncontrollable diarrhea. A lot of patients did not want to be on that drug anymore, regardless of how well effective it was for treating their HIV, so they'd switch over to something else. Or if you find that they're having a treatment failure, right? So if you find that the viral load is still detectable, that will show treatment failure. Maybe the virus is resistant, or what could be the other cause? Maybe they're not taking the drug like they're supposed to, right? They're not compliant with it. Or if you do have a documented resistance, if the genotypic testing comes back and it says, okay, they are, it's going to be resistant to this drug, then you switch them out to something else. So, getting into the complications of HIV and AIDS. So, we talk about opportunistic infections, or OIs, or being things that patients become at risk for, and you'll find this is going to be on a sliding scale based on how suppressed their immune system is. So, for instance, here, if you're looking at their CD4 count and looking at the time as kind of what they're at risk for as time goes on, you can see here, early on, things like bacterial skin infections can be a risk. You'll see that as you get to lower levels, things like oral candidiasis or thrush can be problematic, right? You can find that. What's another cause for patients to have thrush? Inhaled steroids is a common one, but again, if you were to see that, if you didn't have a history of patient had asthma and you saw thrush, like you may think, okay, well, something's going on here. Why do they have this? Maybe they're immunosuppressed and it could be related to HIV. We talk about PJP pneumonias and other things here. I'm not going to cover every single one of these, but certainly you want to be aware of as the levels get lower, you'll find them being at greater risk, and you may need to start what we call primary prevention. We may actually put them on prophylactic medications to prevent them from getting the infection, or we may actually go with acute treatment once they actually develop the case themselves. And you'll find there's a lot of parallels to this with patients who are immunosuppressed from chemotherapy. So actually find that the same drugs we'll give for those patients will be the same ones we give here, because essentially the same process is happening. You're suppressing the immune system, they can't fight off these infections. Whereas if most of you were exposed to things like Candida, you can fight it off no problem. You're not going to get thrush from that, whereas these patients cannot. Not only that, we also have to worry about things like reactivation to latent infections. So if maybe, for instance, they had latent TB, this could be activated as soon as their immune system gets knocked down enough to where they could actually activate and start to proliferate. So looking at this, as I mentioned, we start patients off immediately as soon as they get diagnosed, and the main thing is just to keep that viral load undetectable and keep that CD4 count high. That's going to be the biggest thing to help protect them from these opportunistic infections there. And so ideally we'd like to be able to prevent exposure to an opportunistic infection. That's always a good thing. And then make sure if we can vaccinate against anything possible, that's also going to be helpful to prevent them from getting these infections as well. Again, as their CD4 count gets lower and lower, what do you think it does to, in terms of the vaccine, in terms of efficacy? It decreases, right? Because you don't have a competent immune system to actually develop a response to that. Also, what happens if I were to give like a live virus to a patient who's immunosuppressed? Actually cause the disease itself, right? So again, earlier is better when you're kind of managing these patients here. So as I mentioned, there's going to be chemoprophylaxis that we're going to be using prior to them getting the opportunistic infection, but if they reach a certain CD4 count where we're concerned about them developing it, and then we treat the emergent OI as soon as it happens, obviously. Some patients will go back on what we call secondary prophylaxis, where they are going to be placed on kind of the similar prophylactic regimens before, it's after they've had the disease state itself. And then typically once they have a sustained immunorecovery, we can actually take them off the prophylaxis. So for instance, like with PCP pneumonia or PJP, we'll start them on primary prophylaxis as soon as they get down under a 200 cell count. If they get above that and they maintain that, then we can take them off of that at that point. So as I mentioned, this is not going to be an all-inclusive list. This is just a common couple of things that I see that I want you to be aware of. The full list, you can go back and again at the NIH website. So sometimes you'll find that patients may be diagnosed, again, because it's not always readily apparent when patients have HIV. It may be like a long time before they actually ever get diagnosed, or the opportunistic infection is the reason why they get diagnosed in the first place and you test them. So for instance, if you were to have a patient who developed thrush, you may consider testing them for HIV, and that may be when they actually get diagnosed themselves. So be aware of that. You may actually find that when you start antiretroviral therapy for them as well, that helps them to fight off that infection, because you kind of have to boost up their immune system a little bit. And then look out for drug interactions. You want to be cautious with that, make sure that they're not going to interact. So for instance, rifampin, the TB regimen, is going to interact with a lot of things like protease inhibitors potentially. And then there's something called IRIS here, which is this immune reconstitution syndrome. This is where patients may have had sort of an underlying infection that they couldn't really mount the immune response to, so they didn't have a lot of inflammation. As soon as you give them the ART therapy, all of a sudden their immune system kind of boosts back up, and they feel sicker than they were. That's only because their immune system is kind of coming back online and starting to fight off that infection a little bit. So that's something you may see for those patients there. They end up feeling a lot worse, and it's not the drugs necessarily, it's just their immune system coming back. So first one to mention here is this pneumocystic Jiravecki pneumonia, or PJP. Used to be PCP pneumonia, but now it's PJP. This is probably one of the most common life-threatening OIs that you'll find in AIDS patients here. And again, as soon as they have this is when they actually, this can be like an AIDS-defining illness specifically. And so basically you'll find that PJ is going to be this fungus, has kind of some protozoal characteristics. And you know, a lot of people get exposed to it all the time, but because they have competent immune systems, it's never able to really take hold there. So you may find these patients will come in, maybe presenting like tachypneic, maybe a little bit of fever, cough, and it may just look like a typical pneumonia. But this is something you can test for specifically. Once it cultures out, then you know what you got there. The mainstay for treatment of this is going to be Bactrim. So you use sulfamethoxazole and trimethoprim, and we treat for 21 days. Why do you think that's so long? Yeah, they don't have a good enough immune system to, if their immune system is knocked down enough to develop this infection in the first place, they're not going to have a good enough immune system to help our drugs fight it off. So we give them the Bactrim for a really long period of time there. Now, this is another case where this is a pretty common set of drugs you'll use for prophylaxis as well. So as I mentioned, for instance, if they get down below, say, a CD4 count of 200, we will go ahead and start up Bactrim on them prophylactically. So for instance, if you ever see someone who's on, say, Saturday, Sunday Bactrim, or Monday, Wednesday, Friday Bactrim, or something like that, that typically is going to be related to chemoprophylaxis, again, something like PJP. So we do this a lot in our chemo kids. You'll see this a lot in HIV patients to prevent them from getting the infection in the first place. So again, you use the same drug, you're just using it in a different dosing pattern. So here, twice weekly, 3 times weekly, as opposed to twice daily for 21 days. Candidiasis is another fairly common one. They'll develop these thrush infections due to the Candida just kind of colonizing the back of the throat. And the big risk, though, as we worry about, is going to be this more invasive fungal infection that can develop from this. So a Candida can then translocate and potentially cause more systemic issues there. Typically, we like to, for prophylaxis purposes, can use things like nystatin. Nystatin, if you recall, is able to be used orally, but it does not get absorbed systemically, so very few side effects from that profile, or from that standpoint. And so they can either swish and spit or swish and swallow it, and it's going to be very beneficial to help prevent that from occurring. Can also be used for treatment potentially. Typically, though, if it's more invasive, or if it's, say, esophageal candidiasis, that's where you got to use kind of your bigger guns and go with something like fluconazole, either IV or PO, depending on the severity of disease there, right? Again, this is a case where you don't have any necessary primary prophylaxis, you would just treat it as you saw it. So again, if they start to see kind of minor thrush and maybe start with nystatin, if it becomes more involved, maybe switch them over to fluconazole, so it could be an option. There are lots of other ones that are out there. I just want to kind of cover the two most common ones I run into, but things like cytomegalovirus, herpes zoster, any of these can cause some very significant infections, especially if they become CNS manifestations. Very, very potentially deadly for some of them. And again, it's not necessarily the virus. The HIV virus is going to kill these patients. It's all these opportunistic infections they can develop as a secondary result of that. Okay. Other complications you can see, as I mentioned, these patients are living for longer, sometimes decades after their diagnosis. And like I said, a lot of these patients back in the 80s may have been at risk for these complications, but they just didn't live long enough to ever see them, right? But nowadays, more of these patients are developing diabetes, hypertension, hyperlipidemia. So you really want to be cautious and watch the medications you're going to use to manage that stuff, make sure it doesn't interact with your HIV regimens there. Certain cancers are also going to be a big risk for these patients, and then they can develop an HIV nephropathy, so you do want to watch your renal function because that can certainly affect your drugs as well. So always, always, always double check your drug interactions. If you're not sure, just look it up. It'll take you 30 seconds and it may save a life and save your license. Okay, any questions on that? Yes, ma'am. Say it again? I forgot to put my mic on. I think it's going to pick up most of that. But anyway, I don't know if there's anything specifically saying. I don't know that you could do a trial where you say had a patient with like a CD4 count of 100, like 2 groups of them, and gave one no chemoprophylaxis and one of them chemoprophylaxis. I don't know if that's ever been done because probably not ethical, right? So, but I think we do know that maybe once they saw that they made the recommendations, there might be some retrospective studies showing that doing that does help protect against the virus or protect against opportunistic infections. I'm sure you can find all that information on the AIDS Info website, but that stuff usually gets disseminated down into the guidelines. And that's why we make those recommendations. Okay. Anyone know I put this car here? It's an STI, right? So it's a Subaru. That's what I drive. So, huh? That's not me in the driver's seat. No, that's not. My car's white, not silver. It's very funny because when I bought my car, my wife was like, "You just got an STI and you paid for it?" And I said, "Yes, I did." And then also there's a button in the middle that you can change the settings on the center differential. So when she got in the car, she looks down and she's like, "Your car has C. diff too? Like you just got this thing." I will tell you one other funny story. So one time when I was, I'd got in the car and I lived in like a large kind of neighborhood and I was going for a jog, which is very unlike me, but I saw another gentleman who had his garage door open and he had an STI as well. And so, of course, I had like headphones in, music blaring. I was like, "Hey, I like your car." I was kind of yelling at him and he's like, "Yeah, thanks." I was like, "I have an STI too." Not something you want to yell in the middle of your neighborhood. So we quickly moved from that neighborhood and to other places. But anyway, so let's talk about sexually transmitted infections more specifically. We've all had a good laugh, but these are no laughing matter for sure, especially if you're on the unfortunate end of it, right? So these are common things. You're going to find that a lot of patients may be asymptomatic and may be harboring these, and this is why they spread so easily in a lot of cases here. So we'll talk about gonorrhea first. This is going to be a gram-negative diplococcus, and as I mentioned, has a pretty rapid incubation period and a very high number of people who are made asymptomatic. So it's very easy to spread from person to person without them really ever knowing they had gonorrhea in the first place here. The reason why we're concerned with this, and especially for female patients, is due to the fact that they can have these complications and they may delay seeking treatment in a lot of cases here. So things like pelvic inflammatory disease, which may lead to infertility and ectopic pregnancies. You also worry about more systemic infections that can manifest from this. And not only that, but you actually can find that sometimes infection with some disease states can actually aid transmittance of other ones. So for instance, HIV tends to spread more easily in patients with gonorrhea, right? And also think about sort of the high risk behaviors that may kind of be present here. So you think about like sex workers and things like that. It could be something where you can have a lot of unprotected exposure, making it easier for these diseases to spread. So you're going to find for a lot of these sexually transmitted infections that most of the recommendations are going to come from the CDC, so it's always going to be a good resource to go back to and look up information on how to treat these things and how to manage them. You'll find a lot of these require or recommend just single one-time dosing. What do you think that is? Compliance is the biggest thing. So if you can have a patient come in to say the urgent care or the ER, you diagnose them with something like gonorrhea and then give them a one-time shot of something to deal with it and eradicate it, that's going to be beneficial. If they gave them a 10-day prescription for something or 7-day prescription, they may not take it all. They may not even feel it in the first place. They may still continue spreading that disease to other people. So this is a big reason why we like to use just kind of one and done sort of therapies for these things, because one, we've shown that they've been effective, and two, it helps to prevent transmittance to other people, right? Because again, perhaps the behavior that led up to this infection in the first place may continue on with other partners, and again, the spread can certainly occur there. So here's an example where we would just do a single one-time IM dose of ceftriaxone, right? It retains very good efficacy against gonorrhea, usually just a 250 milligram injection one time, and they're kind of done, right? Also, you know, you could treat every single disease state like that. It'd be great. You just get a one-time dose and you're done. Fantastic. But this is the case where we're also doing it for the compliance purposes. So we don't really like oral cephalosporins as much. We tend to find they don't have as good efficacy as something like an IM dose. So again, this is just an easy, quick way. It's not maybe preferred by patients due to the fact that maybe might not like injections, but it is what it is, right? You tend to find these patients will also get co-infected with chlamydia as well. So again, gonorrhea and chlamydia kind of go together hand in hand in many cases here. And so typically you just recommend treatment for both at the same time. So in this case, you would typically do azithromycin as a 1 gram PO dose, and then they're done. So you may see that combination like in an ER or something where they're getting an IM dose of Rocephin, oral dose of azithromycin 1 gram. That's a very common sort of STI treatment sort of cocktail that you may see there. As an alternative, they couldn't receive azithromycin. This is where something like doxy is going to retain a lot of good activity here. So you use doxycycline, say, twice daily for 7 days. I'm not going to ask you specifically on the dosing, but you should know the medications used to treat these different STIs, what's appropriate for each disease state. Okay. Now, if they have a cephalosporin allergy and it's really true and they cannot receive Rocephin, we don't have a ton of good alternatives here. We have things like maybe like a fluoroquinolone you could possibly use, maybe IM gentamicin, but for the most part, if you can get away with the cephalosporin, it's always going to be the preferred thing there. One thing to also consider as well is like maybe if you have a mom who's giving birth to a baby who the mom has gonorrhea, you also worry about things like eye infections, and so this is actually where you can use erythromycin ointment in the eyes to actually help prevent any sort of infection from developing in those neonates, because again, they are pretty at risk for developing infections. That's one thing you can do. Looking at chlamydia specifically, it's going to be the second most frequently reported STI in the US, actually behind HPV. And so very, very common. Again, you typically find a lot of underreporting in these cases here. So it may be even close to like twice this depending on certain estimates there. This is even more frequently asymptomatic than gonorrhea, which is frequently why you just do go ahead and treat for both. If you have a patient with gonorrhea, you go ahead and treat for chlamydia anyway, just to make sure that if it was there, you went ahead and got rid of it. Again, you have to balance the positives and negatives, and frequently it's better just to treat. So as I mentioned, the 1 gram azithromycin is the preferred way to do it, just a one-time dose and you're done. If that's not going to be possible, then doxy could be used as an alternative, but it's more like a 7-day regimen there. Fluoroquinolones may be useful, but these are going to be preferred to hold back on those mainly because of resistance patterns that can develop to them over time. This is another case where oral erythromycin can also be used to treat these kids who may develop an ophthalmic infection from this during birth. So syphilis is actually is a spirochete, which is not common infection type here. It's a Treponema pallidum. So I always thought it sounded kind of like a Harry Potter spell a little bit, but this is another one that has pretty highly contagious, and again you can see things like rising rates in like men who have sex with men populations here. So very frequent occurrence in these patients. You're going to find also that while the acute infection itself may not be all too terribly exciting, it's the complications they can develop from this. So for instance, they can develop things like neurosyphilis, which may be rapidly fatal, right? So it can be pretty problematic from that standpoint. Here we're going to find that if you needed to treat syphilis, that penicillin G has still retained pretty good efficacy against that over the long term. So it just has never really developed resistance to it. You tend to find that syphilis, the spirochete reproduces fairly slowly, so using like a short-acting dose of a single med is not going to be all that effective. So typically what we end up doing is giving that bicillin. If you recall back in the bugs and the drug section many moons ago, we had that long-acting form of penicillin, which basically comes in that white kind of milky substance. It's an IM dose you're going to administer, and that way it retains that, has that slow release characteristic, and is going to be useful as a single dose to treat for a long period of time there. They couldn't receive that. This is another case where doxy is going to be a big mainstay, but they may need like 2 to 4 weeks, 2 to 4 weeks of therapy. So it can be pretty significant in terms of compliance from that standpoint. So bicillin is going to be preferred for most patients, but for more complicated cases, you may find, especially like more systemic invasive cases of syphilis, this is where we might actually use IV penicillin G. These are patients that are getting admitted, going to the ICU, and sometimes we'll actually give continuous infusions of penicillin G to keep the levels nice and high and treat any of that treponema pallidum as it sort of replicates itself. Next, we have genital herpes. So this is another case where, again, a lot of patients are frequently undiagnosed because a lot of patients tend to be asymptomatic from this. There's two main varieties. There's HSV1 and then 2. Typically see HSV1 doing more like oral pharyngeal disease, HSV2 typically more genital disease. Does that mean they can't switch? They can definitely switch, right? You can have either one in either place there. Again, this can be problematic because, again, it has a high percentage of asymptomatic patients. Even if you don't have any active lesions for those patients, they can still shed virus. And so that'll come into play when we talk about the treatment regimens here for a second. And so obviously the biggest thing is identifying patients who do have it and then actually doing the education. I was looking at some of the stuff up on testing, and it was saying that, and frequently we look at like typical STD screens and things like that. They don't even put herpes on there anymore. They actually took it off the typical regimens. The reason for that is there's so many false positives. They end up having a lot of patients who get diagnosed as positive and not actually have the disease in the first place, right? And so, of course, with like STD screenings, is that something you want to have a false positive on? Probably not, right? Because again, it leads to unnecessary treatment, a lot of anxiety, things like that. So identification is very, very tough. A lot of patients are asymptomatic. So our goals here, if they have genital herpes, they're having an acute outbreak, is to try to shorten up those duration of symptoms as best we can, and then prevent any kind of recurrence. Preventing spread is also going to be a big concern here as well for these patients here. In terms of the pain and discomfort that can come from the ulcerations that develop there, things like, NSAIDs, acetaminophen, all are going to be fine here, but things like sitz baths and things like that can also be very beneficial. Typically, you want to make sure they're using good oral hygiene or good genital hygiene. That way, it can prevent any kind of secondary infections. Because again, these can be painful, they can be itchy, maybe scratching at them. That can lead to a secondary infection you want to be cautious with. So for these patients, when you get the first diagnosis here, typically they're going to be recommending, and just like I think we've talked about acyclovir before, typically either acyclovir or valacyclovir most commonly for these patients for about 7 to 10 days or so. And what that's going to do is help reduce that viral shedding. It will also lead to faster healing and decrease duration of symptoms for those patients there. So you start out with that, and typically the earlier you start, the better. That kind of goes for most viral infections, just like with the flu. The earlier you start, the better effect of your drugs you're going to have there. And then basically all patients who have an active diagnosis for should receive that treatment to prevent those kind of more prolonged symptoms there. We don't like topical therapy. We have topical acyclovir, but it's not going to be all that effective for things like genital herpes. So we do go with oral dosing there. You may find that with patients who are immunocompromised, and I've seen cases of HSV encephalitis before, this is where you're going to need hospitalization in the ICU. You're going to need IV acyclovir most commonly. Anyone remember any particular things to think about with IV acyclovir, or just acyclovir in general? Any patient education points? Renal, what about renal? Yeah, it can develop crystalluria, so you got to make sure they stay really well hydrated, because otherwise that can cause interstitial kidney injury. So make sure they stay nice and hydrated there. Again, we don't like IV acyclovir. It tends to be pretty harsh in terms of like bone marrow suppression and things like that. But again, if it's you got a CNS infection, you got to treat it somehow, and that's the best way to do it. So this is another kind of contentious point here is like, okay, well, patients who, you treat the acute infection, but that's going to be there with them for the rest of their life. How do you manage it going forward? Do you just give them treatment when they develop active lesions, or do you give them something every single day to prevent sort of recurrent episodes from occurring, from happening? What do you guys think would be better? Maybe it depends on how often they have outbreaks, right? What about in terms of, like, say, prevention of spreading to other people? Maybe chronic suppression might be. I want you to exercise your minds a little bit, think intuitively, right? So anyway, typically what you're going to find is that patients that are going to be on more episodic therapy, this is where once they start to develop symptoms, like you got to start it as early as possible. So typically you give them a prescription for them to fill and just hold on to until they actually have an outbreak really occur there. Typically we'd like them to start within 24 hours because you will start to drop off in efficacy in those cases there. This may be better for patients who have, say, more prolonged symptoms or more severe symptoms in those cases. However, you may find that even though they don't have any active lesions at a given time, they may still shed the virus, right? So they may still be at risk for spreading to other people without any active lesions. So in these cases here, you may consider doing chronic suppressive therapy, where you put them on something like acyclovir or valacyclovir every single day, and that does help to prevent a significant number of recurrences. So frequent occurrences, I'd consider doing the chronic suppressive therapy. You also will end up finding less asymptomatic viral shedding. However, we don't know really the full impact in terms of spreading it to other people. So that's going to be another kind of thing we just don't really know a ton about necessarily. Next, we have Trichomoniasis vaginalis. This is a protozoa. Again, fairly common. You tend to find that this is more commonly reported in females, mainly because they are more likely to become symptomatic from this. Guys tend to have either a higher spontaneous cure rate, or they may be asymptomatic. And again, unfortunately, in a lot of cases here, it's easier to spread from a man to a woman. Kind of the just consequences of that. So we tend to find that females are going to be more the ones that are actually complaining of symptoms and need treatment here. Because it's a protozoa, we like Flagyl for this one, so metronidazole is going to be handy. You may have some other agents here like tinidazole, maybe a backup to that if metronidazole is not a good option. Typically, this is another case where we just do a 2-gram dose and be one and done with this one, so that's another benefit of that. This is actually a case here where the laws have kind of been changed such that you can actually prescribe for the partner of the person that you're treating, even if you haven't actually physically seen them, because we know that co-infection rates are so high, and we want to prevent, say if you treated a female that you saw in your office, you don't want the guy to end up giving it back to her again. And so in this case here, you could actually write a script and they can fill that at the pharmacy for the partner as well. So that's another thing, or they just get just a one-time dose of that. So it's another kind of newer development in the past couple of years. So any questions on that? STI, it was pretty quick, but it's kind of like a hodgepodge of different stuff. Yes, ma'am.
When you're treating the partner, do you have to have the partner come in, or like have the prescription?
No, that was the thing. That's the thing that changed in the law. They realized that they're looking at the risk versus benefits, and they said, well, the risk of having a patient have a reaction to that drug is fairly low, but the benefits of treating it and getting rid of it is pretty high. So they said, okay, we're just going to change the law, and you can just write for that partner there. And that person can go to the pharmacy, they can fill it for their partner and just hand it to them. So you don't have to, you don't have to physically liaise on that patient there. You still would document, say, hey, I'm writing a prescription for this other person because they're their partner and blah, blah, blah. So you still want to document that. Yes, ma'am.
I'm noticing a trend where there's Flagyl is
Mhm.
used for a lot of the parasites that have the flagella. So
Mhm.
is that what it originally was made for?
That's originally where it got its start, was just for protozoa typically. Yeah, it's one of the things you think about is having like the best activity against that for sure. What other counseling point would you tell your patient if they're taking Flagyl? Don't drink alcohol. They're like, yes, I got rid of this trick. Time for a drink. Want to avoid that, right? So excited. All right. So getting hepatitis. So we have 3 main varieties we're going to be talking about here with the 10 minutes or so that I have left. 3 main varieties. Do you guys have anything after this?
Yeah.
Okay, good. So I'm not keeping you from spring break.
No.
Good. Okay. You guys didn't seem as antsy as I would expect if that was the case. So, so 3 main varieties of hepatitis we're going to be dealing with: A, B, and C. Which ones are, say, which one do you have vaccinations against? B and A, right? So C does not have any vaccines against it. Which one is, let's see, which one used to be incurable but now is curable? C, yeah, it's actually been a cool development over the past couple of years. But so hepatitis A pretty much is kind of the wimpiest out of the bunch here, pretty self-limiting for the most part, and is very rarely ever going to be fatal. However, you will find that the rates of this has definitely diminished because more and more people have been vaccinated at birth, and frequently this is a common thing that kids will get within the first couple of days of life or so, is a vaccine against Hep A. Typically, you're going to see it's a fecal-oral sort of transmission here. So this is where you'll find the virus gets shed in the feces of affected individuals. This is another case, especially in like more developing countries, where you may have contaminated water sources, and that can be a big spread, cause a big outbreak of hepatitis A. I think in Florida, we actually just the past couple of years or so have had a pretty big uptick in the rates of hepatitis A, and that's been a concern for some people there. But as I mentioned, usually infection is going to be fairly limited. Who do you think might be more likely to have really kind of negative effects, potentially even death from Hep A? Well, neonates, people who are immunosuppressed, and the elderly typically will be more likely to develop more serious conditions or serious issues from this. Also, though, you will develop antibodies against it once you get it the first time. So even if you were never vaccinated against it, but you do get a case of Hep A, you will then be protected in the future. So tend to find that most patients will resolve within 6 months or so. Majority of so will be even faster than that, within about 2 months. Main goals we're going to be seeing for these patients, though, is to help reduce their complications of infection, reduce their actual potential transmission to other people, and then look at the normalization of the liver function, because we will see this will certainly get aggravated. You can see hyperbilirubinemia. They may be develop jaundice as a result of this. The best thing to do, though, would be to actually prevent it with a vaccine. So typically, we would recommend it fairly early on. So, for instance, like 12 months, you can start that. Hep A, I was confused earlier. Hep B you end up starting pretty early on, as we'll see in just a little bit. But anyway, hand washing is probably going to be one of those important things you can do for these patients here to help prevent transmission. So good hand hygiene, especially if you're like preparing food and changing diapers. And again, you think, well, who would be preparing food and changing diapers around the same time? If you're a parent, not just moms, dads too, okay? Wow. Wow, wow, wow. Listen. It's difficult when you go from having to make mac and cheese to changing a diaper back to the mac and cheese. Hand hygiene is king, right? Or queen, as it turns out. But, so that's the big thing. That's going to go on your professionalism grade. You're knocking the dads a little bit. No. Anywho, no, I'm just kidding. I never change diapers in my house. So. I do all the time. So other things we could do, we don't have any specific drug therapy, like any kind of antiviral products we can use for Hep A, but sometimes what we can actually do is give immunoglobulin that specifically is targeted against Hep A specifically. So this would be basically the protein we've taken from donors, people who donate plasma, things like that. We've separated out the ones that are against hepatitis A, and basically we can administer this to the patients. This is expensive and not routinely done, mainly because of the cost and of, most patients just don't need it in terms of their symptomatology. However, if they are immunocompromised, if they are at the extremes of age, either young or old, then you definitely want to consider going to administer the immune globulin. That would be the case for that there. Now, hepatitis B, highly infectious, very easy to spread. And in fact, when most of you get jobs in a hospital, they'll probably test you to see if you have antibodies against hepatitis B. And if you have low titers, they'll probably even give you a booster for it because, again, you'll find healthcare workers tend to be at high risk for developing or potentially spreading from your patients to healthcare providers and back and forth. You tend to find that a lot of patients have these chronic infections that they'll be harboring that allows them to be sort of a reservoir and to potentially spread it to other people. And so this can be pretty problematic. About 650,000 people a year just die from the complications of hepatitis B. So obviously if we can protect against it by using things like vaccines, that's going to be beneficial there. This one can be spread in a lot of different ways, sexually, parenterally, IV drug abuse, things like that. So certainly highly infectious, definitely a concern. Not just HIV, if you're having IV drug abuse or something like that, this is another big one as well. And then you'll find as well, this is pretty common in terms of perinatal infections, so something the mom could pass down to the fetus, so you do want to be watching for that in that patient population as well. So in terms of looking at how we're going to be using this, the vaccine is going to be obviously the best thing to help prevent it in the first place. I'm not going to ask you specific brand names for the vaccines themselves, but I want you to at least know that there is a vaccine available. That's a good point to know. And then you're going to see that we also have immune globulins available for patients that need it. And this is, again, fairly rare that you use it, but they're at the extremes of age or immunocompromised that can be beneficial for them. Okay. Sometimes you can even have patients who maybe have had high-risk exposure, that sometimes you can give immune globulin to them to actually prevent infection if they've never been vaccinated before. So something you may consider as well. Now, the vaccines themselves, this is actually, you'll find it's a fairly low response rate, and so it actually requires 3 doses in order to get optimal protection. Why do you think giving 3 doses helps out with that? You're kind of re-challenging the immune system, right? So you give the first dose, you may not get a whole lot of antibody response from that, but you give the second dose, you re-challenge it, you get a stronger response. And that third dose, you get a stronger response. But you'll find that the durability of that response is not going to be long-lived. So you may have gotten vaccinated against Hep B as a child earlier on, but then you'll find that, like I mentioned, you get the job in a hospital, they'll check you for titers, and if they're low enough, they'll go ahead and give you a booster at that point to kind of re-challenge the immune system and get those levels back up. So that's something you'll see pretty commonly. So in terms of treatment here, obviously we like to get maximal suppression if possible, and if we can, we like to have them seroconvert from this anti-hepatitis B antigen and loss of the antigen itself. So we'd like to have them develop the antibody, but then lose the actual presence of the actual antigen itself, okay? And so this would be present initially, but then once they develop immunity, you'll have them develop this anti-HE hepatitis B antigen, okay? So this is something that some of you, if you've been vaccinated against, would have that present, right? Because you've been vaccinated against this, you already have the antibody. Typically, who gets treatment? Any patients who are undergoing sort of serum monitoring. Sometimes they'll, if they develop hepatitis B, may hold off on therapy and do kind of a watchful waiting approach until they actually develop some issues in terms of like LFTs increasing, things like that. You have to kind of look to see like what's the relative risk of morbidity and mortality for those patients in the foreseeable future, right? So give you an example of what this will look like. So say, for instance, we have patients with chronic hepatitis B and they have the antigen actually present there. They can actually do things like viral count, or they actually do the DNA count there. And depending on what the LFTs look like, they can either just observe and monitor, not really do anything, or they can consider doing treatment here. The reason why we can do more of a watchful waiting approach is because the treatment in a lot of cases tends to be pretty nasty in terms of side effects, as we'll see in just a little bit. And then obviously you want to consider immediate treatment if they develop any like jaundice or any kind of decompensation in terms of liver function. So a couple of drugs we have here. Did we mention interferon alpha before when we talked about cancer drugs? Possibly not. So this is going to be something that actually stimulates our own immune system to fight off the virus itself. It's kind of an immunomodulator, basically like injecting an inflammatory mediator to kind of perk up the immune system to help fight that. So it's going to be, it does have some anti-proliferative effects, which means it can treat some types of cancer. But it could be useful as an antiviral product as well to help the immune system fight off that hepatitis B. You're going to find though that it has a lot of side effects with it, and because it's a protein, it tends to have a lot of costs associated with that as well. We'll look at some pretty nasty side effects in just a moment. So in terms of the adverse effects here, certainly you can see things like risk of infection, especially if like a decompensated sort of patient there. You can end up finding that they have a lot of neuropsychiatric effects. So things like interferon can actually cause worsened depression, suicidality, aggression, things like that. You can also find a lot of issues like autoimmune diseases that can be kicked up by this. So again, not a great set of drugs for the most part. You will definitely find a lot of like flu-like symptoms, because that makes sense because it's stimulating inflammation in your patients there. And then anaphylaxis is a risk to go along with that because it's a protein in and of itself you're administering. So in these patients that they do require therapy too, it can be up to like 24 months, so a long treatment time in order to help try to get this suppressed and have them seroconvert to have the antibody. A couple other drugs we may use occasionally include things like lamivudine or epivir. This is not typically recommended first line, but it's going to be much better tolerated than something like the peg interferon. Also an oral agent, so that's better from that standpoint. And something like adefovir. Again, these are going to be working to usually, for the most part, block the virus from actually replicating by working as sort of a false nucleotide, kind of similar to what we saw with HIV specifically, but it will find some cross-reactivity with the hepatitis B virus itself. Nowadays, I'm starting to see more tenofovir being used here, and so this is starting to be considered first line, mainly due to low resistance rates. And is it possible patients will have HIV and hepatitis B at the same time? Quite possible, right? So again, you can find some double duty being provided by these medications. But other things include like entecavir and talbivudine. They may be used occasionally in terms of like alternatives if tenofovir is not going to be a good option for those patients there. So just some different things to consider as being active against hepatitis B. So I don't think I have enough time to finish all this because how many slides I have left? Too many slides to cover. It's spring break anyway. Do you have any questions on that section? I know we're kind of going a little quick. I'm trying to get back on schedule. Will giving post-exposure prophylaxis early completely eliminate HIV, or can it potentially replicate later on? I think that would be something that you would want to do kind of serial monitoring on to make sure they remain negative. It just has to do with how well suppressed it was. It depends on how early they got the post-exposure prophylaxis started. It just depends on the situation. But yeah, you definitely do serial monitoring to make sure they stay negative for that period of time. Any other questions? Nothing else. I will see you guys next time. 2 weeks, I guess. Quiz is going to be, so the quiz when you get back? Okay, let me see. Hold on, let me look. Look at the syllabus. Syllabus is always going to be our guide. Thank you for reminding me though. So, okay, no class, and then, yeah, you're right, you do have a quiz the week you come back. So it'll be 3-6. So it will go from, let's see, we had migraines left? No, behavioral was not on the test last time. It was only up through neuro, right? So through the migraines. Okay, yeah. So starting at migraines, right, on the neuro stuff, up through behavioral, and then up through, we'll say before HIV. So we'll do up through the STIs. So any of that stuff could be on the test, okay? So from migraines up through STIs, up to and including STIs. Including, yes. Everyone with me? So from migraines, everyone's going to have a migraine after I finish this. So from migraines up to and including the STIs. So that includes all the behavioral section in there, includes HIV, all that, okay? Everyone with me? I hope you have a wonderful spring break. Don't do anything I wouldn't do, which is not much. And I will see you next time.